Good afternoon. Thank you for joining me for this presentation. Today we will focus on major depressive disorder, one of the most common and disabling psychiatric conditions worldwide. We will explore how neurotransmitter theories explain the disorder, how medications act on serotonin, norepinephrine, and dopamine systems, and what the evidence tells us about their risks and benefits. While medications remain the cornerstone of treatment, the best outcomes occur when pharmacological efficacy is balanced with tolerability, psychosocial support, and clinical judgment. This presentation will also evaluate success rates, side effects, and the natural course of untreated depression. Depression has traditionally been explained by the monoamine hypothesis. This theory proposes that deficiencies in serotonin, norepinephrine, and dopamine contribute to low mood, fatigue, and impaired motivation. Cipriani et al. Conducted a large meta-analysis comparing 21 antidepressants and confirmed that medications which increase serotonin and norepinephrine are effective in reducing symptoms. Julian's primer of drug action expands on this by emphasizing that depression is not only about transmitter levels, but also about neuroplasticity. Chronic stress can damage the hippocampus and reduce the brain's ability to form new connections. Antidepressants may help restore these pathways, supporting both symptom relief and long-term resilience. The most common medications for depression are selective serotonin reuptake inhibitors, such as fluoxetine and sertraline. These drugs block serotonin reuptake, increasing serotonin's availability in the synapse. Serotonin norepinephrine reuptake inhibitors, such as venlafaxine, add norepinephrine, which can improve energy and focus. Atypical antidepressants, such as bupropion, target dopamine and norepinephrine, which can be useful for patients who struggle with fatigue. Cipriani et al. Found that all antidepressants are more effective than placebo, but tolerability varies. This highlights the importance of tailoring treatment to the individual. Julian's primer reminds us that older drugs, such as tricyclics and monoamine oxidase inhibitors, remain effective but carry higher risks, which is why they are not typically first-line treatments. Antidepressants provide clear benefits, including improved mood, restored functioning, and reduced suicide risk. However, side effects such as gastrointestinal upset, insomnia, sexual dysfunction, and weight gain are common. Cipriani et al. Demonstrated that tolerability differences across agents influence adherence, which is critical for long-term success. Mortality risk is relatively low with SSRIs compared to older drugs such as tricyclics and monoamine oxidase inhibitors, which carry higher risks of overdose. Julian's primer emphasizes that careful monitoring is essential, particularly in younger patients where suicidality may increase early in treatment. Medication is powerful, but it's not sufficient on its own. Psychotherapy, particularly cognitive behavioral therapy and interpersonal therapy, is highly effective for depression. Kampelman et al. Demonstrated that psychotherapy and medication may target different symptom clusters, suggesting that personalized treatment is essential. Dreisen et al. Further showed that adding short-term psychodynamic psychotherapy to antidepressants benefits certain patients, especially those with more severe or chronic symptoms. Lifestyle interventions such as exercise, sleep hygiene, and social support also play an important role. Untreated depression often persists and carries a high risk of suicide. Spontaneous recovery is rare, and the natural course of untreated depression is typically chronic and recurrent. Artificial intelligence tools such as ChatGPT can summarize treatment options quickly, but they lack personalization. Julian's primer stresses the importance of individualized care, which artificial intelligence cannot replace. Cipriani et al. Provided nuanced data on drug efficacy and tolerability that artificial intelligence may oversimplify. Kampelman et al. Highlight that the treatment should be symptom-specific, something AI tools are not yet able to deliver. AI is best used as an educational resource, not as a substitute for clinical judgment. Clinicians must rely on their expertise, empathy, and patient-specific knowledge to guide treatment decisions. Selective serotonin reuptake inhibitors and serotonin norepinephrine reuptake inhibitors remain first-line treatments supported by large meta-analysis. Julian's primer of drug action provides the foundation for evidence-based pharmacology and highlights the importance of neuroplasticity in recovery. Psychotherapy and medication may be most effective when tailored to specific symptom clusters, and combined therapy can improve outcomes for patients with more severe or chronic depression. Artificial intelligence can enhance knowledge and education, but it cannot replace the expertise and empathy of a clinician. The best outcomes occur when science, patient experience, and human judgment are balanced, a principle supported across all four sources.